I'm going to expect and hope for some good discussion from Dr. Breyer and others who I have not previously met, I don't think, but who clearly know this subject matter more than I do. But previously in the integrated care echo, we did get requests to have some conversation around medication-assisted treatment, particularly the three medications that are most used for opiate use disorders. So I'm just going to walk through that first, just to set the stage, although we all know it. This is the most recent data I was able to find. You can see it was released in December of 21, so they always lag by a year. But notice we've not gone the right direction with this, and COVID is being blamed for some of this 2020 increase. And of course, unfortunately, we may see it not going down in 2021 once we have that real data. So it continues to be a problem. We've had an increase in both men and women. So it's across the board a problem as far as overdose deaths involving any opioid. As a reminder to everybody, opiate refers to naturally occurring substances that come from the opium poppy, such as heroin, and opioid, think droid like Star Wars, man-made. So the opioid tends to get used interchangeably. Opiate, they really are slightly different. Just so you'll hear opiate epidemic and opioid epidemic. They tend to mean the same thing, even though there is officially a term change there. And then again, just so you can see this wave or waves that we've seen. So most of us were not aware we had a problem in 1999. So in fact, I came to the ADM board in 2012 and went around and talked to everybody I could talk to, mayors and the county executive and lots of people, or even Dr. Kohler, our excellent medical examiner. Nobody, and I mean that literally, nobody mentioned opiates as an issue to me. 2013, Dr. Kohler called me and said, "Oh my, we have a problem. We're starting to see more overdose deaths from the opiates." And again, I'm using that now for everything, opiates and opioids. We were starting to see more deaths. And we started at ADM board. The reason I'm saying that partly is the topic today. We immediately put $1 million into buprenorphine across the ADM system, divided evenly with 3 different sites, because nobody was using mostly Suboxone, some Subutex, which is the buprenorphine by itself. And so we immediately started pumping that out to these agencies to get people the care they needed. And since that time, there's been some research on these substances, so I'll talk about that. But you'll notice here, everything's going the wrong direction. The only thing that's dropped some are the prescribed opioids, and a lot of that is due to the ORS reporting, where people with substance use disorders find it hard to doctor shop, because the net result is, as prescribers, we see it on the ORS and so, oh no, you just got Vicodin from your family medicine physician. And they're coming in to see. If they came to a psychiatrist and asked me for an opiate or an opioid, I would be questioning it anyway, because I've never, maybe in residency, I can't remember, but I've really never prescribed these otherwise in my practice or my private practice. So here's Ohio, just to drill this down a little bit further. You can see we have a lot of deaths per year. And this is, I believe, 2020 as well. You'll see that it increased every year. We've seen an increase, not a decrease, not at a high rate, but it's the wrong direction. So either way, it's a problem. And you'll see that we unfortunately are 85% higher than the national average. So Ohio has a big issue. Way back in Independence Day, 2016, Summit County, Akron in particular, was the first recipient of carfentanil in the country, which of course is an extremely potent opioid. And it killed a lot of people in a matter of 3 days. We had a big press conferences trying to figure out how do we help people not go buy the substance. And of course, unfortunately, people with substance use disorders, because of the nature of that illness, their brain believed that they could get some of that, quote, good stuff and be careful. And what they didn't realize is that a grain of salt size amount of carfentanil will kill any human. So I'm not sure how careful you could possibly be when it's that potent. So that is a problem. This is the only slide that's on the quiz later. I'm kidding. So the medication-assisted treatment or medication-assisted recovery, as it's now known in some parts, this just gives you a general quickie overview. We tend to talk about nucleus accumbens mostly, and you can see why. That is the ventral tegmental area as well of the brain has some stage time here with these substances of what used to be called abuse. Now we just say use. And so you'll notice all of these. I mean, they all tending to act in the same basic areas, even the amphetamines and cocaine, cannabinoids, which seems to be coming to a theater near you. Unfortunately, we've got a lot of pressure to legalize cannabinoids across the country. Ohio, just as a quick aside, what we're hearing is there may be a grassroots movement, probably not coming from our legislature. They seem to be not interested in pushing forward on this, but it may end up on the ballot in November, is the last I heard earlier this week. So just be aware of that as another issue, and perhaps we'll need more talks on that particular substance as time goes on. So we're going to focus today on the opiates, the opioids. So you see that attached in here. You see that around GABA, which tends to be our calming chemical in the brain. And so that's the one we look at. So there are really three that we talk about. Methadone, which has been around for decades. Buprenorphine, which we've really only heard about mostly in this time frame of the opiate epidemic. And similarly, Naltrexone, which started, I believe the brand name was Revia, many years ago as a pill potentially for alcohol use disorder. It actually is even more effective in opiate use disorders because it does block the opiate receptor. We'll talk about that. But I don't want to lose sight of the AT part. That is the other treatments. So the medication we'll focus on today, but the psychosocial treatment I do want to talk about a little bit. So when people hear the word MAT, here's a word cloud from a different talk where people had to put in on their phones, hey, what do you think of when you hear about MAT? And you can see a big range here, but notice the way word clouds work is the people who the most responses gives you the biggest font. So hope and recovery show up here as the biggest, which I think is powerful. Notice methadone, also fairly large, which is interesting because it tends to have a bigger stigma amongst society because it came out at a time when we really did stigmatize heroin in particular, people kind of down and out in the gutter in the city back in the 60s and 70s. And of course, that's not really true. And I've read articles, apparently there are still individuals taking methadone who have taken it for decades, who are running Fortune 500 companies because they are on methadone. So the stigma is obviously incorrect, but our society has struggled with that, even though I think the stigma has become better, less during the opiate epidemic, because we've seen so many people. Everybody knows somebody who's had a problem with an opiate use disorder. Sadly, some have known people who have died from it. Other than us in the treatment world, we've all certainly known people like that. So there is maybe a silver lining in the opiate epidemic. We're gradually getting rid of some of the stigma. And COVID, if there's any positive that comes out of COVID, other than jumping us 10 years faster into telehealth than we probably would have, it probably is stigma, because we are starting to see more and more people with mental health issues and substance use disorders due to the stress of that. So just another one. My dogs agree with that statement. So psychosocial treatment. So patients receiving these do, in fact, by many studies, have better outcomes than patients who do not. So it's not just about the medication. Lock them in the other room there. And then the common goals of the psychosocial treatment, not surprisingly, are we're trying to help people modify their behaviors that led them into misusing opiates. So there's a lot more to an addiction, which we use the word addict mostly to mean a substance use disorder, severe, because we now talk mild, moderate, severe in the DSM-5 that came out in 2013. You should be aware that there is soon this year a DSM-5 text revision coming out. Just as a quick aside, a text revision, just like the DSM-4 text revision, will not change any of the diagnostic categories or the criteria within them, but it will add text around research and new updates that have occurred since 2013's publication. So we're trying to modify these behaviors. We're trying to encourage patients to adhere to their medications. So that's part of the whole structure here. And then, of course, there may be, and there often are, comorbid mental illnesses, let alone, we are an integrated care echo here, physical illnesses, right? So we're really trying to treat the whole person, and that is not all about pills. And so we really need to be doing this to help them in the totality to move forward in their care. So here is the actual, there's a slide that I pulled from the DEA. And many of you who myself as well have taken the training, we have an X on our DEA, and it's from the Data 2000. So you'll hear Data 2000 thrown around a lot, and that comes out of the Drug Enforcement Agency. And so these are the three main medication-assisted treatments, the M in MAT, the oldest of which is methadone. It is a true agonist, and I'll show you a couple of graphics of this, but basically what that means is it actually goes on to the mu opioid receptor, and it actually turns it on. So it actually is activating similarly what heroin does, what fentanyl does, et cetera. The difference is it's got this long half-life. It doesn't appear to cause as much of the high or the euphoria that people get from some of the other substances. And so given that activity and some of the psychopharmacology of it, the net, or I should just say pharmacology of it, the net result is that it seems to work well as a maintenance medication. The goal is to decrease the cravings, decrease the brain's constant message, feed me, feed me, feed me, in this case, feed me opiates, so that the person, the frontal lobes can take over again. As I mentioned, ventral tegmental area and nucleus accumbens, those are in the deeper parts of the brain. And so what's happening is in the illness is they tend to start confusing the front part of the brain and making that part of the brain believe that all their behaviors are appropriate because you must have this substance. It's necessary for life, just like food and just like drink, liquids, right? So hydration. So it is a real confusion to the front part of the brain. And so the people sell their parents' TV set. They do all these behaviors in an attempt to survive. We don't understand that as the outsider, where we've really only started to understand that well in the recent decades. So this drug is very successful with that. The problem is, people can in fact die from an overdose of methadone because it is an agonist turning on this receptor. You can see here some heart issues with the QTC interval. Respiratory suppression is the way people die from opiate overdoses. Basically, as you use morphine as the base, you start to give somebody morphine, their brain starts to think, I don't need to breathe as fast. Eventually it thinks, I don't need to breathe at all. Thinking is the wrong word, but that's what happens as far as the feedback loop in there. And of course, the methadone, and I really believe a lot of this started as a stigma issue, has only been offered at the OTPs. So a lot of regulations here. There aren't a lot of these around the state. So we have one here at Community Health Center Addiction in Akron. Dr. Rashidi, who recently finished his fellowship with Dr. Perrin, is now the medical director there since, I think, July. He's very solid. So they have the methadone as well as these others in their setting. Then you have buprenorphine, and I did this sort of in order of action, a partial agonist. This means that it sits on that same receptor, but doesn't turn it on at the level that normally the agonists do, but it also therefore blocks the receptor. So if somebody were to take another opiate or opioid, it generally, the buprenorphine outcompetes those other substances. So you don't get high further because you've already got the receptor bound by the buprenorphine. So similar to methadone, it can be used in detox and in maintenance. So you can give somebody the substance. We've added that to the Summit County run by Oriana House, our detox center years ago through Dr. Gary Thrasher, who does a great job with a lot of this addiction work. He's a ER doctor by background and then went into the addiction world decades ago. And what we tried out was, let's just give them some buprenorphine for detox, as opposed to the cocktail that used to be given to lessen some of the withdrawal effects. And the reality was people were amazingly better. So they used to sit around for 2 or 3 days, not feeling well, not really participating in groups. And then we said, yeah, I gave him the go ahead, basically. Go ahead and start doing the buprenorphine. I had to do that because we have to pay for it from ADM. So he did it. And it actually changed their entire treatment strategy there, because people now 30 minutes later, after their buprenorphine first dose, would come up to the desk saying, I'm bored, where's the groups? Right. And the staff weren't ready for that, because they expected these people were going to have to sit around for 2 or 3 days, not feeling well, before they engaged them in some of the psychosocial. So it really is a sea change for the whole treatment world here. And again, you can see the ranges here. Some of you on this webinar clearly know these better than I do. As far as the ranges. In general, 16 tends to be the number you hear thrown about for the buprenorphine, but there are people who are on much lower doses. In Summit County, when we rolled this out, we attempted an 8 milligram per day dosing. For cost and for expansion, we wanted to get this out fast in 2013. The reality was I only had a handful of patients, if that, where the physicians came back to me and said, this person really needs to go higher. And that higher was 12, even though I know that I got pushback at the AAAP meeting 1 year that I went there from some other experts who said, oh no, you can't ever be less than 16. So there's still controversy in the science over what's the right dose here for individuals. I will also comment that as we tried to our physicians were told, try to get people off of this eventually, just as an experiment in a sense. And interestingly, a lot of people got down to this 2 or even 1 milligram dose. They could not get themselves off of that last milligram or even half milligram. So there may be some other value to this, perhaps even in avoiding depression. There's some research around low dose buprenorphine and depression now. So it's very possible that we'll see that there's more value to this particular substance than we realize. This is a little bit different now. You've probably heard that physicians can now prescribe buprenorphine up to 30 patients, I believe it is. And again, some of the other experts on here can keep me honest if I'm wrong about that. But so they're trying to make this easier. This, I believe, was a compromise. You have an issue with too many opiate pills or opioid pills that were being pushed out into society, mostly because I believe physicians were duped into this, but being told, oh, no, it's not addictive, et cetera. All these things happen with OxyContin, and you're all seeing that play out in the news now. Purdue Pharma just announcing they're willing to give another $1.5 billion to try to make their woes go away, which tells you how much money they have in their bank accounts, that they can just offer that up like no big deal. But so this controversy led to a compromise. So we said, well, we need a way to treat individuals with opiate use disorder. And for whatever reason, they did not make it as easy to give buprenorphine as it is to give Vicodin and Percocet. I wasn't part of that. I don't understand that myself. Maybe somebody on here, the webinar here today does. But so the net result was they created this structure with an 8-hour course for the prescribers to be able to then officially prescribe buprenorphine in the 2 versions, basically buprenorphine plus naloxone, which is the Suboxone, or buprenorphine by itself, Subutex, usually used for pregnant females. And now they're starting to roll that back some by allowing up to 30 patients without that, et cetera, because quite frankly, many people who even bothered to get their X waiver, you know what, the patient population, all the hoops and the red tape, many people that got the X never even used it and never actually used that to prescribe buprenorphine, which means a lot of patients who might have benefited weren't getting it. And then finally, the third one, Naltrexone, again, I believe it started as Revia as a pill form, went generic, got put into a long-acting injectable version from the company Alkermes, so called Vivitrol as the long-acting version. And so there is the oral version, but clearly the injection is the way to go. for individuals. They have to be willing to take it. It's not something you force, but if they're willing to take it, it will actually block the receptor entirely. In fact, so much so that if they go into an ER and need opiates for pain control, they have to make the ER has to know this, because they're not going to be able to really override this. The caveat is, unfortunately, somebody on naltrexone, even though they will never get high, even if they took carfentanil, they won't get high. They can still die because there are different mechanisms. So they could still end up putting themselves into respiratory suppression or respiratory cessation. So that is the one caveat when somebody is on Vivitrol. They need to understand, don't try it. You're not going to get high, but you may die. So that's another big issue. Just a graphic real quickly for everybody. So, and graphically, obviously, this is not what they look like under the microscope, but an empty opiate or opioid receptor. The methadone, as I mentioned, full agonist. So you do get some effect there, but not nearly the euphoria and the high effect. This is from the Pew Charitable Trust, who is getting a lot more into their funding into this arena, because again, certainly by 2016, our country was in a major crisis, including in Northeast Ohio. The buprenorphine then is a partial agonist, so you get some effect, but again, most people do not feel they get high from this. Buprenorphine was not expected to become a street drug, and it does appear to have become a street drug, but generally not because people are using it to get high. They want to keep a strip or a pill somewhere in their back pocket, so they can't get their opiate or opioid that day. They won't go into withdrawal. They can take this, as I mentioned in our detox. It works very well also. So if you are somebody with a substance use disorder, and particularly opiate use disorder, it's not bad to have a couple of these strips or pills, so you have a backup plan on a given day if you can't get your substance, because you do not want to go into withdrawal. These individuals spend a lot of energy not only trying to get high, but when that fun kind of wears off a bit over time, they then move into more of a daily maintenance of their own to avoid withdrawal. And then naltrexone, which completely blocks this receptor. So the goal is, very simply, to relieve those cravings. So your brain's not screaming at you, give me more opiate, give me more opiate. It also helps your body functions to normalize without all the withdrawal horrible things. If you're using this as a way to help in detox, it helps the brain chemistry rebalance. And then, of course, it does block the euphoric effects of other opioids. So there is a lot here that goes on that helps the individual's frontal lobes take back over control. The literature seems to say that may take as many as 18 months of treatment before somebody's frontal lobes are truly fully back in control of them. Here's a little bit more information that I pulled from a different slide set that covers some of it. So obviously the goal here is it works for suppression of illicit opioid use. Notice that the naltrexone is least safe for pregnancy, for, again, integrated care. So any of you are working with patients who may be pregnant, family medicine in particular on this webinar, it is one of the big changes. Naltrexone does not reduce or eliminate withdrawal. It actually would precipitate withdrawal. So if somebody wants to start naltrexone, the person you'll see has to be opioid free. And then this is because there's two theories here, 7 to 10 and 10 to 14 days. And I've also heard bandied about in Summit County around how to make use of this particular regimen. And then pregnancy, a little bit more, just so people have seen what this is with the methadone and with the buprenorphine. Remember, part of the problem is when a woman is on this while her baby's in utero, the baby's born, they're going to go into withdrawal. We've called that neonatal abstinence syndrome, but basically it is opiate withdrawal. And you'll see that methadone tends to have a longer period of time. Therefore, the person may stay in the newborn may be in the hospital longer, or there are places now giving microdosing to send home to give the baby with basically an eyedropper to avoid long stays in an ICU, but help their withdrawal gradually. Buprenorphine has a bit of a shorter neonatal abstinence syndrome issue. So just a graphic of what we're trying to accomplish here. Again, we're really about the whole person. And we're working all the way through this. And we know there's a lot of comorbid overlap with other behavioral health issues with the opiate use disorder. Oops, I jumped past the last one. Here we go. I would be remiss if I didn't mention the other, not really MAT, but harm reduction substance, naloxone. So just real quickly, opioid receptor, that turns it on. Naloxone truly blocks it, as naltrexone blocks it, and the opioids really can't get on this receptor. None of them actually can get on this receptor if naloxone has been successful in occupying the receptor. And as a result, this is what has become used in harm reduction. This is what one of the kits, the more current version of the kits, looks like. So one company was pretty smart. They took naloxone, which had long since been generic, and rebranded it as Narcan officially. So that's what is often in the kits, often bought by ADM boards, such as Summit County ADM board. It's about $100 a kit that we get these distributed widely. So a lot of money goes into harm reduction, Northeast Ohio. In fact, up at Metro Health through Dr. Joan Papp, another ER physician like Dr. Thrasher, who's in this arena. She's very much the leader in thought around harm reduction, which is spread across the region, and I believe even across the country. So you'll see here, there's training that goes with this. Mostly the training is, if you use this to reverse somebody's opiate overdose, they need to go to an ER. And the reason is that those opiates or opioids, especially the longer acting ones like fentanyl and so forth, they will stay in the body and the brain longer than this, which is about 30 minutes maybe. So at 30 minutes point, they could have revived them, they could look great, and they could literally overdose and die on the original use of fentanyl because this wore off and the fentanyl did not leave their bloodstream and therefore their brain. So that's why we tell people that. Notice also, just in our time of COVID here, I'll mention this, face shields. So unfortunate timing, we were all trained in CPR with both breaths and compressions. And then they took the breaths away and said, oh no, just do compressions. And then along came the opiate epidemic. And the problem is those people don't need you to compress their chest for their heart. They need you to breathe, which of course COVID has complicated. Nobody wants to breathe on anybody or near anybody, it seems, for that matter. So these face shields are included in the kit to try to encourage people, you got to breathe for them. The chest compressions is not this. If they've lost their breathing long enough, if their heart has stopped, they're probably dead. Unfortunately, it's probably that simple. So we need to get their breathing going. And of course, sometimes you need to help them out while the Narcan works. So with that, we'll turn it over to all the rest of you experts that know more than I do. Here's my contact information, as always, if you have interest in anything at the Summit County ADM board.